My name is Jessica Bauman. I'm a thoracic and head and neck oncologist at Fox Chase Cancer Center in Philadelphia. And I was just thrilled to be a part of the ASCO annual meeting, in which I chaired an educational session on frontline decision making for patients who have EGFR non-small cell lung cancer. And the session was structured with initially sort of a preliminary focus on what is shared decision making and a little bit more on the patient perspective. And then there were two sides of the debate. One was to consider osimertinib as monotherapy, and the second part of the debate was thinking about combination therapy, either with osimertinib with chemotherapy or amivantamab and lazertinib, which really is the clinical conundrum that we have in practice right now when we have a patient with a new diagnosis. And I will say that the highlight of the experience of chairing this session with me was working with Doctors Alessio Cortellini and Dr. Julia Roto from Dana Farber. Dr. Cordellini's from the University of Rome. And both of them are just brilliant physicians who have really thought deeply about the data and really thought about the subpopulations and what the risks and benefits are of the different kinds of treatments and what the data is to tell us what might be appropriate. And I think all of us had the reaction of after Julia Roto went first, after she gave her talk, I think all of us were ready to prescribe osimertinib monotherapy. And then after Dr. Cordellini's talk, I think all of us were ready to prescribe combination therapy. And so I think that sort of takes us back to what it is like to be an oncologist in this space right now. And that at the end of the day, I think that this decision can be a challenging decision, but it also fundamentally goes back to what patients want, and really what the true benefit of the different therapies are and what the true risks are. And for each patient and their families, they may think about this a bit differently, which is what I had in some ways summarized during my session. I think one is really defining the characteristics of their disease and knowing for us what are the higher risk features of disease. And I think both Doctors Roto and Cordellini described those very well. So patients who have metastatic disease to the brain, people who have co-mutations with TP53, consider potential of liver mets or ctDNA that's not clearing. That I would say are some of the subpopulations within patients with EGFR non-small cell lung cancer who we think of may have higher risk disease. And so I think first is, as oncologists, the first piece is understanding that, and then the potential implications that they may have if we consider a monotherapy approach, that their duration of response or progression-free survival may be shorter, or versus combination therapy, where we may be able to get control of their disease a bit better up front. But I also think then it really is going into the different treatments and how that may impact them in terms of osimertinib monotherapy, which is a pill you take daily, and then eventually, really, we see patients like that often about once every 3 months, sometimes a bit more frequently. Obviously, it depends very much on the individual level, but very much people who are really living their lives and have incorporated the cancer diagnosis into their lives in a really impactful way, but still have sort of live normally, quote unquote, which is the example that Dr. Roto gave, I think was a lovely example of that, of someone who had been on monotherapy for several years. And I think that's versus sort of what does combination therapy look like? There we have two options right now, either with chemotherapy or amivantamab and lazertinib. And what are the risks and benefits of each of those approaches? I think that there are some people who have a lot of negative associations with chemotherapy. So I think when I sort of broach the topic of chemotherapy with people, I have to, yes, of course, talk about risks, but also really help to combat any potential myths that they have from chemotherapy or experiences that that a loved one of theirs had had from decades prior where that potentially was negative. So I think really helping them understand practically what does chemotherapy in this context look like is helpful. And then amivantamab and lazertinib, I think there are a couple of aspects that are important to talk about. One is the skin changes and sort of rashes. That's one of the concerns about some of the toxicity of amivantamab and lazertinib. So talking through how we mitigate some of those side effects is really important as we're thinking about that regimen. But also then, as well as, and then the other piece of amivantamab and lazertinib is the potential for prophylactic anticoagulation. I think that's the other piece that is an important aspect of sort of how it would change their potential daily regimens at home. And then the schedule, the back and forth to the cancer center, and that is one of the risks. It was interesting to me when I was looking at the different kinds of what are called discrete choice experiments, what I talked about in my talk in terms of how patients make these decisions. And there were a couple of studies that incorporated sort of inconvenience to the patient into the decision-making algorithm. And that was less, again, according to those studies, that was less important to patients than some of the other aspects of quality of life, of disease control. And so I do think it's helpful for me to know that if I had to rank these things in order, that perhaps back and forth to the cancer center is less important to some people, but not all. And I think that's at the end of the day, I think you talking through all of these different scenarios and how it may potentially impact a patient and their family, and then understanding what is most important to them and what they're willing to put their bodies through for the different scenarios that we're talking about is ultimately what is so important in our conversations. There are some people where people are working full time in their families, they can't drive, they have to come, they're relying on families and they live 2 hours away, or they live an hour away, but they have to Uber or Lyft everywhere. And any kind of transportation or back and forth is a huge burden and concern for their sort of themselves and their families. I think that those are very real things that happen to patients all the time that we have to think about incorporating. That's not to say that we should therefore not give a treatment when there's back and forth, but it just means we need to understand the true sort of logistical concerns about the treatment that we're proposing. And there are times where we really do think that is the right approach. And so then making sure that we're best supporting patients and their families to be able to obtain the more intensive treatment. I think I would just definitely encourage everyone to watch the debate and then to vote for themselves what they think is best. People ask me afterwards, who won? And I think it's a draw, but but I do think that it was just very thoughtful. And I guess the only other thing to say is that there is also an accompanying article in the ASCO educational book that the three of us put together, in addition to Julia LaCava, who is a trainee with Dr. Cordellini in Italy. And Julia did a wonderful job at really putting together, helping us coordinate this article amongst the four of us. She did a beautiful job leading that as well.